Well, data and maps are only half of the solution to sharing information about healthcare. It's been alluded to a couple times. You also need words. Words are very important when people are talking about. Some people like data, some people want to see the stories in words. And so both of those things are very important when you're talking about healthcare. And there have been a lot of words used to describe the ACA and the changes to the healthcare system. But what words will work best to convey what's important to people who will be most affected by the changes coming forward? So Enroll America partnered with Lake Research Partners and GMMB to survey over 1,800 adults across America who will likely be eligible for the free or reduced cost insurance programs. Then using that, they conducted some focus groups to find out more information about what words people want to hear. And Jenny had pointed out some of those today in her presentation. And now Martine will give us some more insight into the research and share with you some of the things that you can use when you want to talk about healthcare and health insurance with your constituents. So, Martine?
Hello, everybody. My name is Martine Apodaca. I'm the Director of Public Education at Enroll America. We're going to cover a lot of ground, so don't hustle to write everything down if you find something important or whatever. All of my beautiful, really well done slides are right there on your tables. So you can take notes, and if you have a question, I'm happy to answer it once we get through the presentation. So, this is a very happy day. We're now past the 3rd anniversary of the Affordable Care Act's passage. That's President Obama signing the act. Jenny did a little bit of information about who we are and what this Enroll America is. But I do want to make a point of clarification that Enroll America, even though we're based in D.C. and we're working with the federal government and actually very closely with the federal government, we are not a government entity. And Enroll America is a nonprofit that is raising funds from philanthropies and healthcare stakeholders outside of the effort that HHS and the federal government and the White House are going to undertake to maximize enrollment. We have a mission, which is to ensure that people enroll and then make sure that they stay in coverage. All right, so this is a guesstimate of the number of people that the Congressional Budget Office, and this is actually outdated. It's 16 million people in new coverage, I'm sorry, 15 million people in new coverage, and there's a new number as of February, but this is the old one, who they expect to enroll in 2014. That is a very high bar and roughly half the number that they expect to enroll over the course of the entirety of the Affordable Care Act. So I think in 2017 they're expecting around 32 million to have enrolled, but they're expecting the first 15 to 16 million of them to enroll in the first year. All right, so this is the uninsured as a group nationally, and this is an assessment really of what we know already about the uninsured. They're a diverse group. 55% of them are between 26 and 54. As a group, they are mostly lower income. 89% of them are below 400% of the federal poverty level. And if you look at this circle graph here on the right, you'll notice that they're not spread evenly across demographic groups. While Latinos represent, I think roughly at this point, it's a high 17% of the population. They're a full 32% of the uninsured. And this is true and something to take note of, even in states where they're a teeny tiny portion of the populace. In my home state in Texas, it's roughly 2/3 of the uninsured are Latino. But even in a place like Connecticut, where it's 9 to 10%, they're about 1/3 of the uninsured there as well. So this group is going to be disproportionately important in, not that the others are not. Of course, we're going to be working with everybody, but we're also going to have a concerted effort to reach Latinos with messages that work with that particular demographic group. All right, so you can see my home state on the left, the big red anchor on the country in terms of uninsurance. Did you guys know that Rick Perry is the first non-English speaking governor ever elected to a major state? Yeah, I don't know what he speaks. It's not English, but we're all waiting for him to learn. And then, of course, you see our favorite, Ohio, up there as a high rate. And I think Jenny mentioned to you all that it is number 8 in terms of uninsurance. 50% of the uninsured live in the 7 most populous states. That's California, Texas, Florida, New York, Illinois, Georgia, and North Carolina. I think that makes 7. 66% live in the top 12 most populous states if you add Ohio, where we are now, Pennsylvania, New Jersey, Michigan, and Arizona. And so we're going to be going to where the uninsured are with the messages and the outreach tactics that we have. And that necessarily means that we're going to be spending a lot of time in places like Ohio. And I think Jenny will vouch for this. We are here all the time. So I was here, I think, 2 months ago. Jenny was here, 2 weeks ago. And our colleague Anita, who's the Director of State Assistance, is here very often. We've done a couple of enrollment summits here. This place is going to be, and there are an enormous number of Ohioans at this point on our staff. I think it's a cabal, but there are a lot of them. And so we're going to be focusing here, but we're also going to be focusing on Texas, Florida, Arizona, Michigan, and some of the other states you see there. You'll notice that California, of course, which is here at the right, has an enormous number of uninsured. It's almost 7 million people. The difference between the states is that California set up their own exchange, and there are various philanthropies in California that are pouring millions of dollars, and it's not a small amount of money, into making sure that every Californian knows about the options that are available to them, that they know what the exchange is, and they know where to go and how to get assistance in terms of enrollment. That is not true for a lot of these states for a variety of different reasons. Either they chose not to do so, there was not the political will, there are not the funds, or what have you. But in those places, we're thinking about where can we make the biggest difference in terms of getting people enrolled, where can our resources go the furthest, and how can we reach people the most effectively. We want to be able to demonstrate success, and so we're picking those states accordingly. You know, California and New York and some of the others, the larger ones that have established their own exchange, we're not going to be spending a lot of time there. All right, so this, Jenny, you saw the last part in Jenny's presentation, and of course, with a mandate will help, but we're talking about, these are public programs that have been around for a very long time, and you'll notice that on the left side, none of them are at 100%, and I'm certain that none of them got to 50%, as the CBO estimates that we will in the first year, even with the mandate. And I think the right side is probably the most important thing that you all should take away from this presentation today, as wonderful as it is, that there is limited public awareness of recent health reforms, and 78% of the uninsured don't know about the new health insurance exchanges, and 83% of people who could be eligible for the new Medicaid expansion don't know about it. And I can't underscore this enough. So what people do know is wrong, usually. They have a vague idea of what the mandate is. They don't understand that it applies to them. There was a gentleman and I should also tell you, you'll see this in the details of the research, that we did 4 focus groups here in Columbus. And because we're going to be spending a lot of time here, we knew that we were going to be working a lot with Ohioans. We wanted to know what they thought and how they thought about the law. One gentleman in Ohio thought that the mandate meant that you had to do what your doctor told you. Another gentleman thought that it didn't matter if you told, and this was instructive for me because it really informed how we're thinking about approaching this. An older gentleman who is lower on the income scale in Ohio, who has worked in construction all his life, did not believe that Medicaid would cover him because it's never for people like him. And he told us this over and over again. And even when you told him that this was the law of the land and we read the details of what this coverage, these changes would mean for him, he didn't believe us. It didn't matter what we said or how many times we said it. He simply did not believe it. There was another group of people who thought the entirety of the law had been thrown out. And for people who follow this closely, like Jenny and I do and others, and I think probably speaking for everybody in this room, who know when the Supreme Court ruled and who know the details of the decision or whatever, it was really eye-opening to hear that what people did know, they knew very vague details about, and most of it was wrong. Some details about the research. We wanted to know, because we were going to be doing this public education campaign to reach 40 million people, we thought we should learn the most we could about the audiences we were trying to reach and about the uninsured. We wanted to know the most effective messages to reach different demographic groups, who were the best messengers for these communications, and what are the best ways to deliver these messages in terms of the right media mix. How do we talk to young people? How do we talk to uninsured Latinos? How do we talk to African Americans in different places, et cetera, et cetera. We partnered, and this is actually a misnomer now, and if they were here, they would be very upset with me because I like them. Perry Undum is the firm that we use. Lake Research Partners is who they used to be with. They branched out because they do so much healthcare work to do their own work now, and it's Perry Undum Research, the 2 partners we were working with. We did a rigorous RFP process, which is a sort of best practices thing that we should mention. And over the course of several months, what seemed like an eternity for me, we interviewed 23 different firms. We had 11 bids in total, but some of them did joint bids. We ended up going with GMMB and Perry Undum because they are doing a lot of this work across the country for the Medicaid population. They are helping a lot of the state exchanges brand themselves and figure out how to reach particular populations. And they were working with a lot of these demographic groups and groups that we were going to be working with already. So we saved ourselves a lot of time by partnering with this particular group of firms. So Next, some more details about the research. The sample consisted of 1,814 adults ages 18 to 64 with incomes at or below 400% of the federal poverty level. So we wanted to know a couple of things. We wanted to know who the person was who made the healthcare decisions in a family, who can convince others to make good healthcare decisions. And Jenny alluded to this a little bit when she was talking about the folks who are uninsured are not necessarily who we're going to be targeting, and I'm going to mention a little bit more about this as well. It's going to be who's going to convince these folks to enroll, or who's going to actually be doing the physical enrollment in many cases. So what is their experience with the healthcare system? What do they know about the health coverage options coming in 2014? What's going to motivate them to check out the new insurance options, and how do we contextualize costs? How do we test perceptions of affordability? And I'll say right at the outset, that this is going to be one of the biggest challenges for this campaign and everybody in this room in terms of figuring out how you talk about the value of insurance for folks who are, particularly folks who are lower on the income scale, and to make the choice seem like a choice that is right for them and something that they can afford over the course of the long term. And I'll tell you now that we have done a lot of work here, but we are not there yet. In fact, I know that we're going to be working on how to contextualize costs and how to talk about affordability and some more research work that we're going to be doing over the course of the next several months. So, some more details. November 13th through 18th last year in Philadelphia, Columbus, San Antonio, and Miami. We did English and Spanish-speaking Latinos, African Americans, young adults, parents, low and moderate income, childless adults. We also tested the brand and the name of the campaign, which you all should know is not called Enroll America. And I forgot to put the slide in here. Shame on me. The slide, the campaign is going to be called Get Covered America, Your Health, Your Choice. It's a beautiful American flag waving in the background. We didn't pick that by accident. I thought it was going to be a little bit hokey for people to have the American flag, but it made them feel inclusive. They love the word America in it, particularly the Latino audiences. And Your Health, Your Choice conveyed control, it conveyed optimism, and it made people feel like they were in control and secure, which is how they want to feel when they're buying health insurance, when they were making health decisions for themselves or for their family. So just to clarify, Enroll America will continue to be the parent organization, but the National Public Education Campaign about enrollment in health insurance is going to be called Get Covered America, and the tagline is Your Health, Your Choice. But before we dive in, here are some of the key findings from some of the state exchanges and others and some of the philanthropies. You all remember my name, right, so I can take this off. It's Martine Apodaca, but this is getting in my way. From the state exchanges that are doing a lot of this research work, some key findings, and this is a relief to me because I thought we were going to find regional differences about the value of insurance or demographic differences. We didn't. Everybody wants and values insurance. It was 90% of folks, even in our own work, valued and understood the value of insurance and didn't think it was something that they could live without. The difference here was cost. The second was perceptions of affordability are going to be one of our biggest challenges to overcome. I think I mentioned that earlier. There are universal messages around the exchanges. In other words, they're all talking about these exchanges as like consumer-friendly places where you can buy and get insurance. I think one of the things that I want to do over the course of the next several months is manage everyone's expectations, who I'm speaking with, about what the process is actually going to be like for consumers. Because a lot of folks, even some of the folks who are running some of the exchanges, have characterized this as being able to go to Amazon.com and shop for different products, or being able to go to Travelocity and book a plane or a flight or whatever. That's not how it's going to work. And as this process has moved forward, I think it's more akin to doing your taxes than it is to going over there and then clicking a few things and voila, you're done, right? And it's important that people know that that's what it's going to be like at the outset, because if they go to the Amazon.com of insurance and it is indeed not like Amazon.com, they're going to be upset. So I think it's important to make sure that people know that this is going to be a process that's going to take some time and some commitment on their end. And the other thing is that there's deep skepticism among consumers. And you'll see this in our research as well. And it's something that we need to be able to talk about and to acknowledge when we're going to deliver a message about how to enroll or what you should be thinking about when you're in terms of enrolling. Insurance is confusing. That is true for me as well. And in many cases, we're talking about folks who've never had insurance. And so talking to them about, and most of the folks who we're talking about have not had insurance for 2 or more years, talking to them about a deductible or a premium is very confusing, much less what is covered in the fine print or whether there are any gimmicks or what have you. Number 6 we mentioned earlier, and then number 7 Jenny talked about everyone wants help enrolling in coverage. That is true among all age groups. There is even a plurality among young people, the people who you would think would be most likely and most comfortable to be able to finish something like this on the internet. Even they want in-person assistance to make a decision like this. So this slide is fun. I actually thought when we got this word cloud back from the pollsters that the word enraged would show up right in the middle, but it doesn't. And I think they just did us a solid and chose not to include it. But if you had to look for health insurance now, what feelings do you think you would have? You'll notice that stressed, overwhelmed, worried are the biggest words there. They want to feel confident, informed, secure, satisfied, and in control. Most of the message work that we do as a result of this, of how they feel and how they want to feel, is trying to get them from there to there when we're talking about insurance. 44% of the folks we're talking about have shopped for insurance outside their job. And like I said, 2/3 of them, 67%, have been insured, in terms of the uninsured who were represented in our sample, have been uninsured for more than 2 years. And the saddest part about this, and I'm just going to stop there and add some details from the focus groups, when you ask them, how many of you, if you're uninsured, have medical debt, everyone raises their hand. And then if you ask them, how many of you have more than 2,000, almost everyone raises their hand. And then some of them have so much medical debt that they don't get insurance. And even the ones who do have low medical debt don't get insurance because they can't afford it. But paradoxically, they don't get that if they have another accident, they're going to be even worse off. So it's a problem that we're going to have to overcome when we're talking about this. Next slide. So, and this is important too, and this is going to be particularly important for particular groups. And like I mentioned before, 44% have shopped for health insurance outside their job. They thought it was hard to find a plan they could afford, hard to understand the fine print, hard to find a plan that covered the care they need, hard to know where to look, and they were denied for a pre-existing condition. And so the pre-existing condition part is going to be particularly important, and we're actually working on this for some of the major disease groups in terms of how they choose to talk to their particular constituencies about getting health insurance. And one of the questions I got, we're building partnerships with a number of different people, but I was talking to one of these potential partners, and he was very confused about, it was a corporate partner, about the disease groups and wanting to know how to talk about a pre-existing condition. And he said to me, don't most people with cancer or a heart condition have insurance coverage already? And I said, no. And it seems a little weird because he thinks that because they're ill, of course they're going to go out and get coverage, but that's not how it works. And a lot of the folks who we're talking about, especially if we're talking about communities of color, a heart disease or diabetes is a chronic condition, and part of the reason it's chronic is because they don't have insurance. So it's important for us to be able to acknowledge things like this and talk about where people actually are when they're thinking about buying insurance and what their experience has been before. So initial reactions to the new coverage options in 2014 are positive. Nearly 70% express interest in learning more about these options when they are presented with basic information about the new coverage. And I'm going to read this to you. I hate reading my slides, but I'm going to read this one to you because it's important. So this is what we presented to folks when we were talking about to them in the focus groups. As you may know, and it's interesting what people could get around and what they couldn't, and I'll talk about that too. As you may know, in 2014, there will be new health insurance options for you if you need insurance. Most people now have health insurance through their jobs, and that will not change. But if you do not have insurance, or if you lose insurance, you will be able to find a quality health insurance plan that fits your budget. The Latinos in the audience, many of them could not get around, particularly at the low income level. Most people now have health insurance through their jobs, and that will not change. The questions that we got asked in the Spanish groups in particular were, how can you have insurance if you don't have a job? And if you lose your job, how are you going to be able to keep it? And it didn't matter how you tried to explain it, they had a really difficult time with that concept. So their skepticism, 38% do not think they would be able to find a plan that they could afford, and 33% would find a plan that covers all the care, do not think they would find a plan that covers all of the care that they need. So this is like the high watermark of where we start from, but this is sort of the good news, and then there's going to be some bad news. So I like this slide because, and I have to make fun of Tressa for this. Tressa's the woman we work with best at Perry Undum. It says sample premium amounts may not seem affordable. Only 29% of people think that this is affordable, but it says may not seem affordable instead of don't seem affordable. So after being presented with a sample premium amount for an individual or family of four at around 250% of the federal poverty level, only 29% thought it was affordable. But that's a fancy way of saying that we went to the Kaiser Health or the Kaiser Family Foundation and used the premium calculator to determine what we thought, at best guess, someone making 250% of the federal poverty level would pay in terms of premiums, because we knew what the subsidy would be. It's a subsidy calculator. And we tested that. Only 30% of people thought it was affordable, 16% were neutral, and 53% said it was not affordable. So you all understand why we need to do more work around perceptions of affordability. But it seems more affordable when they consider the yearly savings. And so the important thing to take away from this slide is not that 29% thought it was affordable. It's a context count. So when we're talking to folks about insurance, it's important to contextualize either what they save over the course of the year, what the premium would cost if they were paying for it by themselves, what they would have to pay for a particular procedure, or if they broke a leg or had to go to the emergency room or whatever. When you compare the two, then people can see that there is a value to having insurance, right? When they read that this will help your plan save XYZ dollars a year compared to what you would pay on your own right now, 51% said it was affordable. And starting out, I think it's Latina women say that they're the most likely to say that they could find a plan that they could afford. But I think they're and if I remember correctly from the report we did on Latinos, their support drops to 21% when you actually give them the price tag. So it's important not to give people sticker shock. And in many cases, particularly on the lower income spectrum, we're talking about people in some groups where a tax return may be the biggest financial moment of the year. So giving them a premium amount of thousands of dollars for insurance is probably the least helpful thing you can do because it seems overwhelming. And in many cases, the first time that they're going to be talking about this is when they do their tax return. So it's important to know that you have to contextualize things and make sure that people understand the difference between what they would pay on their own and what they would pay with insurance. So how do we get around this? We use messages that tap into security. And the messages we came up with, and all of these I should say, security is the overarching umbrella, whether it's financial or health security. And the messages were, if you or a family member gets sick, you won't have to worry about big medical bills or going into bankruptcy. 2, the insurance plan you choose will be there to cover all of the care that you need. Many people have had bad experiences where they got kicked off of their insurance for going to see a doctor for a particular condition. And then 3, you will be able to find a plan that fits your budget. And then a message that taps into all of these 3 security themes reaches 80% of the population and 76% of the uninsured. You neutralize their skepticism about affordability by, 1, contextualizing things. We were talking about that earlier. Saying financial help may be available using sliding scale for lower income. And this is interesting because I thought when we were designing the survey that no one would understand what sliding scale means. But the alternative I proposed was based on how much money you make or based on your income or what have you. But we tested this with both the folks who were Medicaid eligible and the folks who weren't. And sliding scale works really well with the Medicaid eligible because they have experience with public programs and they know what that means. It does not work for people who are not. So based on how much money you make works for, I would say probably before the expansion, probably a larger portion of the populace, but post-expansion, sliding scale will probably be appropriate. Second, specifying total savings an individual or family could incur in a year. Using a security theme value message. A security theme value message example would be peace of mind. And then using a specific Medicaid income range and free or low cost in messages among lower income audiences. So in broad messaging, we introduce top facts. And the top facts, these 4, the first 2 of which are the most important, all insurance plans will have to cover doctor visits, hospitalizations, maternity care, emergency room care, and prescriptions. The second is you might be able to get financial help to pay for a health insurance plan. If you have a pre-existing condition, insurance plans cannot deny you coverage. And the last is all insurance plans will have to show the costs and what is covered in simple language with no fine print. That was particularly important in focus groups for people who had been denied or kicked off of insurance. And then a message with all 4 facts reaches 90% of the population and 87% of the uninsured. This means that for 89% of the population, the most important fact they need to hear is one of these 4. So here are the takeaways broadly so far. That there's going to be a lot of initial interest, that we need to acknowledge where people are and what their experiences have been with the health system and shopping for insurance. We have to lead by telling consumers what's covered, that they'll not be turned down because of pre-existing conditions and that they could get financial help. And we have to talk about financial security. It is the top message among all groups. Affordability is our biggest challenge, which we've talked about, I think, extensively. And then we're going to have to meet them at Google. Most of the folks who we're talking to, in fact, all of the demographic clusters that we identified, everyone, when you ask them where's the first place that you're going to go to get information about purchasing coverage, they may not feel comfortable filling out the application online, but the first place they'll go is to Google. They're all going to look for it. We asked them what they were going to put into Google. It was like affordable health options, quality health insurance, et cetera. But everyone's going to be going to Google. All right, so here are the 5 clusters of targets that I keep talking about. We have the uninsured, unnecessary, and uninterested, the reluctant but reachable, the desperate and believing, the connected low-income women, and insured but at risk. This is the demographics we're most interested in is not true for the exchanges, many of whom will be delivering messages, not just the uninsured. So they have something different to do than we do. We have to drive people to the exchange, but they also have to brand the exchange, market it as a consumer-friendly product. So they're not just going to be talking to the uninsured, they're going to be talking to everybody, because people might have insurance, but they might think it's too expensive or crappy insurance, and thusly they should go to the exchange and find something that's right for them. All right, so the demographic profile of the uninsured, 18 to 64, below 400% of the federal poverty level, 52% are women, 48% are men. They are lower on the education spectrum. 67% have been uninsured for more than 2 years. And you can see that 22% of them are Latino, 16% African American, 55% are white or non-Hispanic. So the first demographic group that I mentioned before, the uninsured, unnecessary, and uninterested, they are skeptical. They're mostly men, they are younger. You'll notice some of the interesting demographic groups. They're the least connected to Medicaid, and 45% of them are Southerners. These guys, the good news is that they're movable, and this group, as a rule, are the folks that HHS in their public education and outreach campaigns are going to be the most focused on. And the reason they're most focused on them is because the exchanges need this demographic group so that the whole system works. They need, I only have 5 more minutes. They need these guys to make, the folks who aren't going to use insurance the least, because insurance works when there's the broadest pool and the young people aren't using the resources and the sick are using the bulk of them. They're the least connected to Medicaid, I said. They're only 3 to 4% are interested in new options. But when you give them some basic information, particularly information about financial security and the mandate, they get more enthusiastic. And Perry Undum had identified these gentlemen for us as the uninsured, unnecessary, and uninterested. But if you look at the bottom, and this is a misnomer too, it says top messengers are going to be a family member, spouse, or mom. It's actually mom. I joked with Perry Undum that we should rename this group the Mama's Boys, because she's who is going to convince these guys to enroll. All right. So I'm going to fly through these. So this is among the youngest clusters, and it's the lowest income. It's a high Latino and African American cluster. They're young, diverse, and uninsured. They're among the least educated, the most likely to express soft interest in the new options. Most of them are interested, but only 1/3 of them are super. If I were to characterize this group, it would be the meh, we can't afford it group. They want insurance, but they're reluctant to look because they don't believe they can afford it. And they almost universally, this group and others, say that they're going to go to Google to get information. The desperate and believing, this is our sickest group. This is the heaviest Latino sector. It's also one of the sectors that is the poorest. They are the low-hanging fruit in terms of initially convincing people that there is something that's going to be out there for them. They want to enroll. So that it's the group that if you build it, they will come. They're the group that's going to seek out a Medicaid office or someone from state government. They're the second most connected to a Medicaid office. I'll talk to you about the one that's the most connected. And this is interesting because this group, while they might not, and I think Jenny alluded to this earlier when they were talking about a state government employee whose job it is to help you walk through this, they don't like necessarily going to a Medicaid office, and I think most of the folks would say it was a big to-do to do so. But they appreciate the knowledge and know-how that they get once they're actually speaking to someone at the office. So I think the underlying thing here, along with the findings about the insurance companies, is that people want someone knowledgeable. A lot of the groups that we're talking about who have been kicked off for a pre-existing condition or are uninsured now have very negative perceptions of the insurance industry writ large. But when you ask them who they would go to get information, the insurance companies are one of the first places that they would go to get this information, because if insurance companies implies knowledge, same with the Medicaid office. And the important thing here is that people want in-person assistance, first of all, but second, they want someone who's knowledgeable about it. All right, so these ladies are the connected low-income women. They are the most connected to public programs, usually to their children. This is the lowest income sector. 77% are going to be Medicaid eligible because they're under 138% of the federal poverty level. This group sees insurance as necessary overwhelmingly, and the top two messengers are someone like them who is enrolled, but also someone from a Medicaid office. And like I said, 60% of these folks are in contact with or have experience with the Medicaid program. The insured but at risk, these are people who work in industries. They tend to be younger, but they also work in industries where there's a lot of turnover. They tend to be service workers. There are at-risk folks. Most of them have insurance, but they are teetering on the edge and self-identified themselves as being at risk of losing it. Like I said, one of the youngest clusters, and like the first cluster, because they tend to be younger, they express the least interest in the new options and enrolling in coverage. All right, I'm not going to read this stuff to you because you can see it all on there, and you guys can have electronic copies of this. Some of the fine-tuned messages from the states, a lot of them, and I consider security to be a peace of mind message. It's the leading perceived message among several populations in several states. Prevention was a key message for women. Protection from financial ruin and injury resonated most with men and young adults in some states. Access to care was particularly important for African Americans, Latinos, and the Medicaid eligible. Low cost or free health insurance, key message, and nothing super like groundbreaking here, right? But nonetheless, it's good for people to see. Key message for low-income Medicaid eligible, and the law and associated penalties was the biggest motivator in Massachusetts, where the typical uninsured person was a 37-year-old male. All right, so what does all this mean? Great, Martine, we know a lot about the uninsured. What are we doing with it? We're using this research work and the subsequent research projects, and by the way, I should mention that we have distilled this even further because we have such a large sample size, into reports on women, the uninsured, Latinos in English and Spanish, African Americans, and young people 18 to 29. We are also working with several partner groups to do the same work with the LGBT community, and we're also doing additional work on affordability and perceptions of affordability. We're going to be using this to do a broad-based national campaign that will have paid advertising on TV, radio, and the internet, constituency engagement like this, but also with Latinos, African Americans, women's groups, gay groups, faith groups, etc. Creative use of social media, earned media events, and we're doing this with a number of different partners. You all will see them develop over the course of the summer. I can promise you that Ohio will see a number of these because we're going to be working here a lot, and there will be staff here helping to organize these things. I should clarify right now that, because in case this is a question, that we are not going to actually be doing the physical enrollment. We are going to do everything up to physically enrolling people in terms of convincing them to talk to their friends and neighbors, and telling them where to go and who to talk to, and then handing the baton off to the actual state agency or navigator or assister that's going to help them enroll. There's also going to be a data and analytics and micro-targeting portion of this. That's really going to help. What we're doing is building a national database of the uninsured and assigning a likelihood that a particular person is uninsured at an individual level. So we're purchasing a lot of consumer data and a lot of publicly available data that has been done by the private industry for a number of years, along with the federal government, to help us determine what is the likelihood that Jenny Sullivan, who lives in Columbus, Ohio, is uninsured. Where does she live? What's going to convince her, or what have you? We're also using this algorithm to help us determine where, not just where we have a high concentration of them, but thusly where we send staff and where we send paid resources. So that is the lightning version. And then this is the campaign timeline. We are in the second phase. We have done the first phase mostly. We're building an organization, launching the education and awareness campaign sometime in June. And from October 31st to the March 31st is the first open enrollment period. We expect that the national advertising campaign on radio, TV, and outdoor advertising will begin in earnest sometime in late August or September. We may do some over the course of the summer. And then once the open enrollment period ends, we're going to have a debrief and try to revamp and figure out what worked, what didn't, before we ramp up again for the next open enrollment period in October of 2015. All right. And of course, this is how we're going to be working together. We are interested in making sure that whatever it is that we do is not duplicative, which is why it's so helpful for us to be here at these events, to know what everyone else is doing, so that we're not creating something out of whole cloth that you all have done and done really well in Ohio. And like I said, we are coordinating with HHS in the States. I don't mean that we're coordinating sounds very loose. We're actually pretty tied at the hip with them. We are not a government agency, but we do know what they are doing. We know which states they're going to be active in and what our role is going to be relative to theirs, because the worst thing that we could do is raise a boatload of money and then spend it in exactly the same fashion that HHS is, or target exactly the same consumer, when we really could be reaching a whole lot of people. And that is it. Thank you all. Do you have questions?
Sure. This is great information for us to have to give to people so that we can help them feel better. Recently, there's been discussion about Congress being exempt from this. How do you plan to smooth that over? I mean, because people might not be happy with that.
They will not be happy, and fortunately or unfortunately, because I think that's the dumbest idea ever, we are not working on that. And here's the thing that I should mention. We're not talking about whether the Affordable Care Act is a good thing or a bad thing. And part of our effort as an organization is to talk to people as consumers and patients, not as political actors. And that is a political story that's wrapped up in Harry Reid and John Boehner's BS. So I mean, if I were a member of Congress, seriously, I don't know why on earth I would try to make myself exempt from the very program that they sold to the American people as something that they themselves would have to participate in. But that being said, that's not something that we will work on or spend any time on. Any other political issue, we don't work on Medicaid expansion in the states, for example. A lot of you are maybe working on that. We have not touched that for obvious reasons. I know that Jenny in her heart of hearts, and me too, would love that if we worked on that. But that is a radioactive issue and not something that we're focused on. So we're working not just on targeting the Medicaid eligible, but people who are eligible for subsidies and the uninsured writ large without getting involved in any of the policy fights. Yes?
It's not clear to me. You're not a government agency, but does that mean you're a private, not-for-profit that's being hired as a consultant by the states?
No, ma'am. I will explain. Enroll America is a consortia of healthcare stakeholders, insurers, pharmacies, pharmaceuticals, community organizations, consumer advocacy groups, etc. And it was hatched by Ron Pollock, who is also on the board, who is the chair of the board, but he's also the executive director of Families USA, which is a consumers organization, with the idea being that now that we've passed this Affordable Care Act, who the heck is going to do all of this enrollment work, right? And who, if you look at the daunting statistics, is going to tell 40 million Americans that, surprise, there's new options for them. And so we've built this organization over the course of what is now two years, and nobody paid attention to us in 2012. But that has changed now that the election has gone a particular way and the Supreme Court has ruled that the Affordable Care Act is still in existence. We are not a government organization. We are a nonprofit organization that was going to do this enrollment, outreach, and education work anyway. A lot of the people who are on the board are stakeholders, so they have a vested interest in hospitals, for example, and people having insurance and coming to the emergency room with actual ability to pay. Same with insurers. They stand to benefit from this. We thought, why not merge the two interests? We want everyone to get enrolled as consumer advocates, but they want everyone to get enrolled for a different reason, and that's fine. A lot of the people who are on the board did not have the same position on the Affordable Care Act or whether it should pass at all. In fact, some of them vehemently disagreed and still do. But we all agree that now that there is coverage available, Americans should know about it and they should enroll in it. Is that more clear? And we're working with the federal government because we know that there's going to be a critical component, but we all know that there are limited resources to do this kind of work, and to do it at scale means that we can't afford to waste any of them. So we're coordinating closely with them, with the state exchanges where it's appropriate, and with outside organizations. I'll give you another example. One of the partners that we're working with in Texas, for example, is the Texas Blue Cross Blue Shield, who is doing what's called a Be Covered Texas campaign that the insurance company is running all by itself. They're not branding it as Blue Cross Blue Shield. They're basically spreading messages about enrollment and the benefits of having insurance without saying you should enroll in Blue Cross Blue Shield. We are helping and facilitating and fostering efforts like that across the country where we can and where it's appropriate, and not promoting one plan over another, but really talking to people about what's appropriate for them and what's appropriate for their families and what level of coverage they should get or what have you. So that's what we're doing.
I know there's a couple other questions, but I also want to make sure you guys have enough time to eat lunch and get going to our breakout. So Martine and Jenny will be here the rest of the afternoon, so if you have other questions, they will be available for you.
Thank you.
I know